when the bronchoalveolar markings are not enhanced, you may not expect the bronchi. It may be only the preparations which could be heard. Now, one more of the X-ray. Again, technical qualifications part. This also is not taken in full inspiration. It's in the partial expiratory phase. Centering is not proper. See, it's not exactly proper. The spine, the shadow of the spine is not in the exact midpoint of the intersternal spaces or the clavicular ends as such. It's more towards the right side. And as a result of that, the aortic knuckle seems to be prominent. This aortic knuckle prominence need not be considered as evidence of the disease. That's all the important thing. Now, the other features which you can see are, there is again, the hilar shadows are increased and there are many of these opacities seen. Now, these opacities which you see in the hilar area, you can compare it to the previous opacities. Now, in this X-ray, when you have seen the opacities in the hilar area, this opacity is very dense and it has a very clear outer margin, and it's the density is totally different from the other surrounding area. I think you can make out that. Some of the shapes of these opacities are irregular, not perfectly circular. So this kind of an opacity suggests of a chronic calcification over the area, calcification over the lymph node as such. Whereas the opacity which you see in this second X-ray, the calcification, here you can see that there is a appearance of circular appearance, and the density of the opacity is more towards the periphery. Core area of that opacity is still not having the same density. And this kind of appearance is also called as signet ring appearance. Technically, we use the word signet ring appearance, which suggests of an ongoing calcification. When the calcification occurs in the lymph nodes, the calcification occurs more in the beginning over the exterior. Then gradually the interior, the medulla of the lymph nodes would be involved. So cortex is involved in the beginning, the medulla will be involved later. And hence, all that what you can make out is the history of calcifications in the lymph node. That means the inflammatory pathology is relatively shorter in this patient, whereas in the other previous patient, the history is longer. Now, in this X-ray, the third X-ray which you have seen, you can see again the same, the signet ring appearance. Classic, typical calcification which has occurred in a circular fashion, and it has a ring-like appearance. The outer surface of the calcification is just merging with the soft tissues around, whereas the inner surface is perfectly circular. It has a very smooth appearance. Are you able to make out that? I think it's possible. And you can see many of such shadows. Whereas some of these areas of calcification, there is a density, hard density. Now, this again is a hard density. A hard density calcification suggests of a more chronic inflammation, whereas that signet ring-like appearance is of a lesser duration. Now, if you read the radiology textbooks of Western authors, even to have one or two calcifications or one or two lymph nodes visible in the hilar area is considered as pathological. But in India, in our situation, almost every X-ray, every 100% of the X-rays would have at least 3 to 4 lymph nodes visible. So presence of the visible lymph nodes and presence of a few of the calcifications may not be very considered as a pathological condition in our situation. Reasons could be many. Again, there could be lots of hypotheses, like because we are more exposed to pollution and so on. That's not the important point. The point is about having that the calcifications need not be considered as abnormal in every X-ray. That has to be correlated with the clinical history. If the patient has a chronic history, then you will have to consider that these calcifications are important. Now, anyway, the point is about these calcifications and their variables. Then the mottling is seen. In addition to this mottling, in this X-ray, what you can see is in the right lower lobe, particularly in the third and fourth segment area particularly, you can see these bands which are almost vertical to the ribs, not parallel, and their diameter, these dimensions are not tapering. See, in a vascular marking, we have discussed that in the initial class. A vascular marking would be almost parallel to the ribs, and then it gradually gets tapered towards the periphery. Whereas a fibrous tissue marking may not have that kind of a limitation. It could be of any shape, any size, so on. Now, in this case, you can see a band-like structure, which is almost nearly vertical to the ribs, and that shape, it's not really tapering. It's wider, somewhere it is narrow and nodular-like. Now, this is suggestive of a fibrosis. Fibrosis suggests of a chronic changes in the inflammation. If you know that, if you have studied the pathology of inflammation, you will have the different phases of the inflammation. The first phase is the vascular phase, where there will be exudates. Then there will be the stage of cellular phase, where the phagocytosis would occur. And then the stage would occur where there will be fibrosis. The fibrous tissues will migrate to the area. And then it may end in calcification. The last part is the calcification, where the fibrous tissue is covered by the calcified tissues, so that the inflammation is buried down. So that's the usual course of inflammation. Of course, if you study the inflammation, you may have many other terminations. There could be pus formation, and then the whole termination could occur. But this is one of the cause as such. So development of the fibrous tissues in the lungs is suggestive of a chronic changes. So we may term this condition as a chronic over acute bronchitis. Now, there are terminologies used to cover or acute over chronic bronchitis. That's the terminology. Acute over chronic bronchitis. When you say a chronic bronchitis, from the clinical history point of view, there should be a minimum history of 3 months of continuous pulmonary symptoms without complete resolution. Then we can say that the condition is a chronic bronchitis. But from the X-ray point of view, radiological point of view, whenever we see these fibrous bands, that suggests of the chronicity, and we may say that it's a chronic bronchitis, but presence of these exudates, mottling, that suggests of an acute pathology, acute inflammatory condition. So we may say that it's an acute on chronic bronchitis. To confirm about the chronicity, you have the other evidences. Some of these lymph nodes are fully calcified, some of the lymph nodes are in the partial stage of calcification, so that whole process of inflammation is a continuous ongoing process. So at different stages of inflammation, you have different structures. So that's suggestive of a chronic bronchitis. From the clinical science point of view, a chronic bronchitis would have a prolonged history, and characteristically the patient may have exacerbations periodically, whether it may be due to the seasonal factors or other factors. There could be exacerbations, but characteristically, patient would not be absolutely symptom-free in between the intervals. So there could be episodes of aggravations, but in between the patient may not be totally symptom-free. And on auscultation, you will hear a fixed rhonchi, which is constantly seen. In every breathing, you will hear the rhonchi at this area. That's the difference between an acute inflammatory pathology and a chronic inflammatory pathology. In an acute inflammatory pathology, rhonchi may be inconsistent. At times it could be seen, at times it may not be seen. Whereas in a case of chronic bronchitis, the rhonchi are heard throughout. Every breathing, you will hear the rhonchi. And most of the times, the rhonchi are biphasic. Both inspiratory and expiratory phase, the rhonchi could be heard, and that's because of the fibrosis. And the reason is simple, because the tube is narrowed permanently, it produces the obstruction during the breathing in as well as breathe out, the inspiration as well as the expiration. And usually the inspiratory rhonchi would be louder, expiratory rhonchi are less louder. That's because the pressure of the air flow during the inspiration is always more than the expiration. So you will have a biphasic rhonchi with a louder inspiratory phase and less intense expiratory phase, and of course the crepitations heard at that area. The patient would have expectorations, but expectorations could be of different colors depending upon the presence of the septic foci, causes of infection. That could be even, it could be purulent, it could be yellowish, greenish, or so on. The color can change depending upon the organism which has involved. And the chronic history is characteristic in this kind of a situation. So that's about the clinical signs. In addition to that, in addition to this, there is one more sign which you can see. If you look at the border of the mediastinum, heart shadow, particularly on the left side, the borders over the border, you can see some thick wool-like structures, gun wool-like appearance. Are you able to make out that a relatively less opaque and a soft spongy-like substances? This also is sign of the X-rays accumulating over the lung area, and it's also suggestive of the chronic bronchitis. That's often called as a silhouette sign. This sign is called as a silhouette sign, where you will have some extensions around the pericardial area. We'll have better examples of the silhouette sign later. Now, one more X-ray. Now, here in this X-ray, again, positioning is not perfect because the patient is not positioned parallel. Oblique centering is absolutely incorrect. So you can the centering, the midline of the spines is almost on the right side. The external border is overlapping. So and hence this aortic knuckle, which looks to be prominent, need not be considered as a important entity. The features which you see are the other, of course, soft tissue shadows are otherwise normal. Exposure is slightly overexposed X-ray. X-ray is taken in inspiratory phase. Costophonic angles are normal. Cardiophonic angles are obliterated. They are not seen. And over the mediastinal border, the same gun wool-like appearance which I referred to in the previous X-ray, it's more prominent. Virtually, you are not able to make out exactly the cardiac border. The cardiac border is continuous with the surrounding area, and this is again the typical silhouette sign, a standard silhouette sign which you see. And the area lung air entry to the right lower lobe as well as the left middle lobe fourth segment is, and you can see these extensive thick hairy linings, like irregular linings, like some of them are thick, some of them are less thicker, and presents on both the sides with relatively lesser amount of the exudates. Mottling is seen in a few of the alveoli towards the periphery. Apex, the lung tissue is normal. Hilar shadows, of course, there are many of these hilar shadows, the opacities in the hilar area. Some of them in the signature appearance, some of them in the advanced stages as such. Now, this is suggestive of a chronic, more extensive fibrous changes. So, it's also a bronchitis, but in this case, it's more of a chronic bronchitis where fibrosis is more than the inflammatory changes, that exudative changes. Exudative changes are not conspicuous, fibrous changes are more. In a patient who has that extensive fibrosis, the clinical symptom will be there will be a reduced lung compliance. So, because the lung tissue has become fibrosed, it cannot expand properly, and hence patients' tolerance of the exercise will be markedly reduced. And this would be clinically presented as a dyspnea on exertion. So, in a typical acute bronchitis, patient may not have a dyspnea on exertion, but when it becomes chronic and when it becomes fibrosed, because the lung compliance becomes reduced, lung compliance in the sense capacity of lung to cope up with the increased demand of oxygen during the exercise, as it gets reduced, the patient would have a reduced exercise tolerance, and the dyspnea on exertion could be the clinical symptom. So that's how a evolution of a bronchitis pathology can be seen clinically, and a corresponding changes in the X-rays also can be seen. So this evidence of the fibrosis could be visible in such X-rays. Now, to highlight the same issue, what you can see under the gross. Now, I think I have. In case of a bronchitis, in case of the lung tissue, in a gross lung tissue seen during the inflammatory phase, you can see the normal area and that inflamed the bronchitis area. The bronchitis area, there will be more of exudates. It's a gross appearance, what you can see over the surface of the lung tissue. There will be more of exudates, and the area of edema can be seen, whereas the normal lung tissue would not have the exudates. These exudates are filling in the alveoli. So as you look at the microscope, you may see the alveoli filled with these exudates seen. See, this is one of the alveolus, and in the alveolus you can see the exudate seen. That's in the acute phase. Whereas in the later phase, the chronic phase, the alveoli would be replaced by the epithelium will be replaced by the fibrous tissue, irregular fibrous tissue, more of exudates, and these along with the exudates, you will have all the other debris filling in the alveoli seen. So that suggests a chronic changes as such. Now these effects are seen in the X-rays. So whenever you have this kind of a vision of an alveoli under the microscope, you can imagine that in the X-ray you can expect a cavity-like appearance, that behave-like appearance with this fluid which is opaque. So the mottling produced is due to the same, whereas the increased density seen is when you will have the alveoli filled with these opacities as such, and then of course the fibrous tissue is developing, that becomes more opaque to the X-ray. So to conclude, in typical acute bronchitis, alveolar patterns are seen, and in that alveolar patterns you may see a slightly that dot-like appearance, or what we call as a mottling, could be seen. Generally, it doesn't result in the change in the volume. In a case of acute bronchitis, even if there is a moderate this fibrosis, the volume of the lung doesn't get changed, and hence it may not really produce a displacement. The density of the lung tissue can be slightly increased. So this all is called as the mottling as such. So that's one of the consequences of the inflammation of the lung tissue, which we clinically call as a bronchitis. Now, when the inflammation becomes more chronic and there will be more of the microbes involved, then there will be the further changes. The inflammatory this fibrosis occurs, and along with the fibrosis, there is a continuous destruction of the alveoli, and hence the alveoli also they become dilated. Initially, the alveoli would be having a grape of bunch-like appearance. Now, these alveoli become flattened and they become a bubble-like structure. As a result of that bubble-like structure, the whole diameter of the alveoli would be enhanced, and hence that condition is called as a bronchiectasis. Bronchiectasis is the word meaning of ectasis is dilatation, a dilatation of the alveoli, which is one of the possible chronic long-term consequence of inflammation of the lung tissue. Now, once the bronchiectasis occurs, clinically, the clinical signs will be patient would have a purulent expectoration, the pus-like expectoration would be there, and because the alveoli would be dilated, the patient would have more of expectoration, and that expectoration would be always related to the posture. See, some areas, suppose in this patient, when the patient lies down on the left side, this area where there is a lot of exudates, that will be easily flowing out, and hence the patient will have more expectoration when the patient lies down on the left side. So there will be a postural effect, or postural effect of the drainage could be seen, because the exudates are more and they are present in a dilated cavity, they can passively flow over the area. Now, and auscultation in case of bronchiectasis, you will always hear very coarse crepitations, characteristically leathery rails, very coarse crepitations would be heard. And because the alveoli will be dilated, the inspiratory phase becomes shortened. The air can move into the alveoli easily in a shorter period. And in between the inspiration and the expiration, the gap becomes enhanced. And this kind of breathing also is called as bronchial breathing. The bronchial breathing would be where the phase between the gap between the inspiration and the expiration becomes enhanced. Intensity of the expiration would be, compared to the normal, would be louder, and the inspiration sound would become shorter and less intense. Tendency to have that kind of a feature. Normal, the inspiration would be quite loud and expiration would be relatively very low intense sound. And there is a tendency for change in these intensities, and that's called as the bronchial breathing. And in a case of typical bronchiectasis, you'll have the bronchial breathing, whether leathery rails seen due to that dilated alveoli. These dilated alveoli would be seen as what we call as a beehive-like appearance. What you can see in this X-ray, in the right, middle, and the lower lobes, second, third, and fourth segment area, there are extensive these irregular shaped cavities, larger cavities than that of the real alveoli. To confirm about that, to make it more visible, I have taken up this much of the image and dilated this, enhanced, like the size is enhanced, so that you can make out these appearances very clearly. that beehive-like appearance is seen, and that's the suggestion of a bronchiectasis. Bronchiectasis is usually a chronic long-term complication, and whatever you see as this is an artifact, a button of the patient, of the dress material of the patient. So that's about one of the other consequences of the inflammation, bronchiectasis. Next consequence would be pneumonia, which we will discuss in the next session. We will continue that in the next session. If there are any questions, there are some questions. Is there a restriction of metallic objects for a racer? Yes, like I'm not able to read that question properly. Like is there like MRI? No, so I think, see, unlike MRI, with the X-rays, there is no restriction. If a patient has a metallic object, there is no restriction for the X-ray. In MRI only, presence of metallic and electrical active components are not to be allowed, because that will make the body temporarily magnetically active. Then there is another question, like in cervical rib is present congenitally when it gets detected only after a certain age. So that's it. A huge number of cervical ribs would be remaining asymptomatic only when they produce a compression of the nerves, brachial nerves. There could be the symptoms of the outlet syndrome. The compression of the thoracic outlet could occur due to cervical ribs. Usually, this compression is related to either a weight gain or weight loss. If a person gains weight, then the structures could be slightly displaced, and if a person loses weight also, that also could be a triggering factor for the displacement of the structures, and hence usually the onset of the symptoms are related to this incidence of weight loss or weight gain in a patient of a cervical rib. Then there is another, is a fibrosis of lung is reversible. No, anywhere once the fibrosis occurs, the fibrosis is always irreversible, and hence the fibrosis is once fibrosis occurs anywhere, it's irreversible. That's all about these questions, I think. If there are no more questions, we will wind up. Okay, fine.
Thank you, sir.